The third lecture in our Geriatric Healthcare Lecture Series for winter 2018. My name is Barbara Cochran. I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this series with thanks to our funding agency, Health Resources and Services Administration, or HRSA. And I just want to remind those of you out there in Cyberland to please be sure, if you haven't already for this series, fill out a profile form, as well as be sure that you have an evaluation that you can fill out at the end. Both are very important for our ability to continue to have very effective lectures and receive funding for doing that. If you know of people who are very interested in any of our lectures that have happened or are going to be happening but can't make the live presentation, they can go to our website, and that is www.nw, as in Northwest, GWEC, so nwgwec.org, and the lectures are posted for free within about 48 hours of when they are presented. Now, those lectures are not available for continuing education credits, but if you're just wanting to expand your minds, then you can go to the website and get that information. So I am very pleased to introduce to you today my boss. Elizabeth Phelan is Associate Professor in the Gerontology and Geriatric Medicine Division with the University of Washington School of Medicine. She's also an Adjunct Associate Professor of Health Services with our School of Public Health. And she's an affiliate investigator with Kaiser Permanente Washington Health Research Institute. And she directs the Northwest Geriatrics Workforce Enhancement Center and is founding director of the UW Medicine Fall Prevention Clinic. And it's her director work with the Northwest GWEC is why I say she's my boss, and she's actually the person who leads this whole initiative. So thank you very much for doing that.
My pleasure.
She is clinically active, a fellowship-trained geriatrician. Her clinical work encompasses the inpatient and outpatient settings, and she's involved in teaching principles of internal medicine and geriatric medicine to students, residents, and fellows. Her research aims to promote health and prevent functional decline in community-dwelling older adults, and it focuses on improving quality of care for geriatric syndromes, including falls and dementia. So welcome. Elizabeth is going to be talking with us today about choosing wisely for older adults in primary care. Dr. Phelan.
Thank you very much. Good afternoon, everybody. It's a pleasure to be here. I first want to acknowledge a couple of wonderful sources of information for this presentation: the American Geriatric Society and the American Board of Internal Medicine. And I have nothing to disclose. Just an outline here of what I hope to cover this afternoon with you. First, I want to just give a brief overview of Choosing Wisely. What is the Choosing Wisely campaign? And then I'll go into a number of the principles that the American Geriatric Society has developed for choosing wisely, specifically for older adults. And they are ones that are most relevant for people in primary care settings. And at the end, assuming we still have time, I have a few cases, and then I'll welcome any cases of yours that you might want to present and other questions at that time that relate to this evidence that I'll show you.
Elizabeth, do you mind if I interrupt? One thing I forgot to say, so I'm hoping you folks can hear me, and that is if you could save your questions to the end.
Sure.
I will then read them off the chat screen at the end of the series so that you can hear it.
Great, thanks. All right, so let's get started. So first, the Choosing Wisely program or campaign. What is that campaign? So this is an educational campaign developed and led by the American Board of Internal Medicine. And its goal is to try to help patients select care and treatment options that are well supported by evidence, that help them avoid harm, and also those treatments and approaches to care that are really truly necessary, avoiding unnecessary care. And different medical specialties have developed their own set of these types of choosing wisely guidelines. And they focus on either procedures or treatments that are oftentimes, as in the case with care of older adults in geriatric medicine practice, very ingrained in practice. So at this point, most fields of medical care have their own choosing wisely principles. And these are well referenced. So if you look at any of them, you'll see key references for each of the principles of practice. And this slide gives just a screenshot of Consumer Reports. Consumer Reports has partnered with the Choosing Wisely enterprise to produce patient-oriented, patient-friendly, easily digestible recommendations based off of these Choosing Wisely guidelines. So these are Googleable, and you can find those on the web. So currently there are five plus five, if you will. The American Geriatric Society first issued a list of 5 and then added to those. So I'm going to show you those just briefly to get a feel for how they're phrased, what they look like, and then we'll go into the ones that I selected in some detail for discussion. And we'll talk about why these principles, what's the reasoning behind them. So you can see here there's 5, and then the second set that came out subsequently. They're in their first iteration. To my knowledge, there hasn't been a second iteration editing these or adding to them at this point. So I won't read through each of these, but you will have those on your handout. You can see them on the slides. And you can look these up again and get the background information for the ones I won't cover today, if you're interested in those. So the ones I selected are on the next couple of pages, and we'll go into each of these. So one related to feeding tubes in people with advanced dementia, use of antipsychotics in the setting of dementia, use of benzodiazepines and other sedative-hypnotic medications, use of appetite stimulants for people who are losing weight, and then lastly, prescribing practice, prescribing medications, how to approach that in a very broad sense. So first, let's look a little bit at tube feeding in people who are suffering from advanced dementia. And this principle says, do not recommend percutaneous feeding tubes in people with this condition. Instead, offer what's called assisted oral feeding. So what's the basis for this first principle? So first of all, we know that as dementia progresses, people have increasing difficulty with swallowing, and as dementia becomes advanced, people often have difficulty measurable, if they're so tested, in clearing secretions, and tend to have trouble with what we call aspiration. Dementia also is associated with difficulty, certain difficulties, including apraxia and inattention. So these are also contribute to increasing difficulty with feeding oneself. So in response to this, so concern for aspiration, difficulty to actually get food, proper nutrition administered, it's been somewhat of a tradition that a so-called percutaneous feeding tube be placed to facilitate feeding, and the belief has been that this would prevent aspiration. And what's interesting in practice, and you may have seen this in your own setting, that actually the discussion around this is usually about risks of the procedure, complications of the procedure, rather than a broader discussion of treatment options. So the possibility of the tube is not, in other words, weighed against other options. And so this sets up somewhat of a dilemma for people who are trying to gather information and they're not probably getting a complete picture about what their options are. So this challenges that practice. And this is because of literature showing that feeding tubes are not only not helpful, but they have inherent risks. So why aren't they helpful? So it's hoped or expected that there would be some benefits, that people would not continue to lose weight, they would eat better, and that this could, as a result, allow people to be healthier, avoid pressure ulcers and other sort of risk of wounds. That, of course, pneumonia might be prevented, particularly an aspiration type of pneumonia. And even that perhaps this could improve function and prolong life. And in fact, none of those things have been borne out by a limited literature looking at this question. And in fact, the risks are actually, risk of complications are fairly high. If you look at the rates there, anywhere between a third to over 2/3 of people with such a tube will experience one of these complications that I've listed here. And it's everything from, if they're short-term feeding tubes, certainly some of the upper airway infections are more prominent, but this is referring to the more permanent so-called percutaneous feeding tubes, issues with tube care, skin condition around the tube, tubes falling out, tubes getting clogged, etc. And in fact, pneumonia continues to occur, and what we've learned over time is that aspiration pneumonia is not prevented as it had been expected by placement of these feeding tubes. And in some settings, people become much more anxious, distressed when they have such a tube placed, leading them to be oftentimes more agitated and resulting in placement of restraints, immobility, risk for and development of pressure sores, etc. So can lead to a cascade of complications beyond just the care-related and maintenance of the tubes themselves. So what is the alternative? The alternative is, again, what's been called oral assisted or just simply hand feeding. What is this exactly? This is essentially what infants, toddlers do, which is you put food in front of them that they can pick up with their hands, and they either eat it themselves or you help them. So why is this important, and what does this help? This helps preserve one of the single most important pleasures that we as human beings experience, which is the pleasure of the taste and the satisfaction of eating. It also actually allows much more human contact and interaction that's of a humane nature as opposed to more of a mechanical or technical nature of hanging a bag of food to administer through a feeding tube would. It also seems that weight loss is mitigated, and it allows, with proper timing and pacing, the opportunity to cue a person with advanced dementia to actually eat in a safe manner. So, for example, asking them to clear their throat, to cough after they take a bite, to take small bites, to take their time, and then it becomes a more engaging interaction for both parties. And a lot of the other things that we do to people, in addition to administering food via a tube, such as give them medications to calm them down, or treat them with other medications that may cause GI side effects. These are also things that we can look at along with this hand-assisted or oral-assisted feeding. In other words, any drug that contributes to dry mouth, which might impair swallowing, we would want to look at that as providers and say, well, how necessary is this medication? Is there an alternative approach? As well as looking at any medications that are going to make people not feel like they want to eat. For example, medications that contribute to nausea or to a lack of appetite, such as a couple that I've listed here. The second principle is, again, in the setting of dementia, the use of antipsychotics. This choosing wisely topic says, do not use antipsychotics as first choice to treat behavioral and psychological symptoms of dementia. Again, a common practice over the years, and let's look at why, what about this setting is problematic. So as we know, as dementia progresses, people often develop what we call behavioral manifestations of dementia. They might become very restless, agitated, even be disinhibited or physically or verbally, behaviorally resistant to care and or aggressive. Things like spitting, biting, etc. And these behaviors tend to increase in frequency as dementia progresses and regardless of the etiology of dementia. And one of the most salient issues around this for families is the fact that this makes care very difficult and contributes to caregiver burnout and to placement as a result of that challenge of care on a daily basis over the course of many years, because this condition progresses oftentimes, in most instances, rather slowly. So it's a chronic caregiving situation. And again, the tradition has been we can use a medication, i.e. an antipsychotic, to reduce the level of these behaviors, allow us to manage them. And similar theme you'll see, not only is the evidence, the weight of the evidence not in favor of that in terms of the benefits, but also the balance, the risk-benefit balance is not there supporting ongoing use of antipsychotics, at least as first-line therapy. So why is that? So a number of studies have looked at use of these medications in the setting and have shown that the behavior really isn't improved much. Probably what happens is people become quite sedated, so they just tend to sleep, disengage, and then they of course have the complications of the drugs that we'll look at in a minute. So quality of life, functioning, again, not improved. Some studies, again, there's a black box warning for use of these, increase the risk of stroke and mortality, and are associated with increased costs of health care. And in addition to just sedating, there's a whole host of other complications that I've listed here, or risks that we do see. So worsening of cognition, which of course we don't want. We want to optimize cognition in this setting. And we want to optimize alertness in a normal diurnal manner, so awake during the day, not asleep. So sleep is promoted and preserved for nighttime when everybody else needs to get rest. Aspiration pneumonias, again, probably due to sedation. Orthostatic hypotension. A lot of these drugs have strong, especially the older drugs, have strong anticholinergic side effects, including orthostasis. And again, rigidity. People become much less mobile, even with slight, effects on the body's musculoskeletal system from these drugs, and increased risks not only of stiffness and rigidity, but the consequences of that often falls and complications, the injury complications related to falls. And again, these black box warnings in recent years showing increased risk of death, cardiac sudden death, probably from the common adverse effect of prolonging QT interval. And then I mentioned stroke already. And for at least one of these drugs, olanzapine, the emergence of diabetes, probably unmasked due to some weight gain that accompanies this drug use, along with dyslipidemia. So what are the alternatives to use of these medications? One of the key things here is trying to identify what the unmet needs of this individual might be. And at some level, it's a guessing game, but certainly having a list of things to check, these things such as I've listed here on this slide, and just run through those when these behaviors manifest. So, for example, and this, this applies generally if you're seeing a person, of course, in primary care or in the hospital or other setting. It's not unique to primary care, but things to discuss with a patient's caregiver if you're seeing them in the primary care setting. Pain, issues around bowel and bladder function. Are they hungry? Are they thirsty? Do they feel, too extreme of temperature, either too hot or too cold? Is there an infection brewing? Is there stress in the home environment? It can be broader, it can be psychosocial as well. It's also believed that the caregiver's level of stress can be conveyed and transmitted to a person with dementia, and that stress, if that can be reduced, can help reduce the adverse behavioral responses. Again, similar to our first choosing wisely topic, medications here may be contributing to problems and worsening these symptoms. And these are medications that are acting on a brain that's already having difficulty with performance. So again, medications that are so-called CNS active or central nervous system acting medications, the medications that might have anticholinergic side effects, of which there's, of course, a huge list, and medications such as benzodiazepines or non-benzodiazepines that are often used to promote sleep and also thought to calm people down to help with these behaviors. They may be even being used concomitantly with an antipsychotic. These medicines will worsen cognition, and when people don't feel well, they are more prone to the behavioral disinhibition and disturbances that we see. Some other sort of practical things that we can talk with caregivers of persons with dementia, providing care at home, if we're seeing them in our clinical settings, are to just try to figure out if there's any environmental stressors. I mentioned that a bit around ambient room temperature, but lighting can be important. Level of noise or commotion in the environment can be a factor. Setting a daily structured routine and sticking to it can be very helpful in keeping people on track in terms of being behaviorally under normal, behaviorally normal. And exercise. One of the few studies that has a good randomized trial around it is this one out of the University of Washington, showing that daily exercise improved not only functioning and general functioning and mood, but also helped reduce the level of behavioral symptoms and behavioral disturbance. Commonly recommended are distraction and redirection, so not engaging if somebody is maybe saying something that isn't quite right, not insisting that that you correct them, but just trying to gently change the subject and reduce focus on something that they may be perseverating on. And then increasing the opportunities for social interaction so that people get a chance to talk about things from their past which they can still often connect very strongly to. So that's the basis for things like groups that talk about, that are reminiscence groups, and also use of the untapped parts of our brain, often the creative parts of our brain around art and music can be helpful in engaging in hands-on activity. And then finally, because that caregiver is so important to the well-being of this individual, and their psychological well-being is important to maintain and preserve, making sure that the caregiver supports are optimized. And just, as one example, adult day health, if that's available in a person's community, wherever you practice, this would allow, for example, the opportunity for regular ongoing respite throughout the week. A list here of common problems that caregivers cite in caring for people with dementia, and again, some solutions. So I'm not going to go through each of these, but we've touched on a lot of this. So argumentativeness, avoid debating, change the subject. Some of these we haven't covered: toileting issues, scheduling, voiding, to make sure the person doesn't go too long before they have an opportunity to empty their bladder. So I'll let you look at some of this in more detail on your own time. The next topic is the use of benzodiazepines. And this statement says, do not use benzodiazepines or other sedative hypnotics in older adults as first choice for management of insomnia, agitation, or delirium. And I mentioned a bit about agitation. This is, again, behavioral disturbance in the setting typically of dementia or in delirium. So I'll focus primarily on the use of this medicine now in the context of insomnia. And sleep becomes precious and fleeting as we age. Over half of older adults endorse trouble with sleep, and trouble on a chronic basis, not just intermittently or short term. And 1/3 of older adults take some form of a sleep aid. And these days, people can get not only a benzo, but they can get the non-benzodiazepine agents like zolpidem, and they can go to the pharmacy themselves and just pick up some Benadryl or some Tylenol PM or Advil PM, which has Benadryl in it, and have a for they're relieving their pain and supposedly helping their sleep. But in fact, they're not helping their sleep, and they're exposing themselves to risks by taking these medications, and we are when we prescribe them. For all of these medications, benzos and the Z drugs alike, and these over-the-counter agents that I've just mentioned, there are minimal improvements in studies of sleep quality and sleep duration as a result of taking them. And again, thinking about that risk-benefit, the balance between risks and benefits, the risks are greater than the benefits. So what are those risks? Everything from confusion, disorientation that persists, doesn't just exist within short-term use of the drug, but can last until the next day, but also fatigue during the next day. Dizziness, some drugs, nocturnal wandering or sleepwalking has been observed, and substantial increases in injuries, falls, hip fractures, motor vehicle crashes, and crashes leading to hospitalization. So what can we suggest if not prescribe one of these medications? So the first thing to do when somebody is discussing trouble with sleep with you is to think about, well, why might they be having trouble sleeping? We'll, apply our diagnostic, primary care hats and think broadly but also think of the most common things being common. The things I've listed here are exceedingly common contributors to insomnia in later life: depression, GERD, gastroesophageal reflux, nocturia. Sometimes people are up, I see people who are up as many as 5 and 6 times a night to go to the bathroom. Imagine that effect on sleep. Obstructive sleep apnea, still likely well underdiagnosed, and just simply pain, keeping people uncomfortable, unable to fall asleep, or any combination thereof. So we can look for these things, ask about them, and some of these obviously require more of an evaluation than others. Next step would be to try to invoke lifestyle interventions, and there are a whole host of things that we can recommend to people. If you're looking for good resources, there are some good resources on this that I can provide. But generally speaking, what I find is that most patients haven't ever had a discussion about this, or it might have been incomplete. And there are specific lifestyle behaviors, habits, have not been addressed specifically in this context. Many older adults, for example, nap in the afternoon. They're tired, they nap, setting themselves up for an ongoing cycle of poor sleep during regular nighttime hours in bed. And this has been termed sleep hygiene, which is sort of a interesting term, but if it's a way to remember this, talk to your patients first about sleep hygiene before immediately reaching for medication. Cognitive behavioral therapy has actually been demonstrated to be more effective and also a more durable effect than taking medications when looked at in head-to-head trials. The biggest challenge with cognitive behavioral therapy, which essentially delves into some of these, certainly would delve into some of these lifestyle modifications, but then would help with things like anxiety due to poor sleep ongoing, and the anxiety that might occur when somebody gets into bed and worries they're not going to fall asleep, for example. The biggest challenge is trying to find a practitioner of this type of cognitive behavioral therapy, but just to be aware there is good evidence for this approach. Melatonin is an over-the-counter agent that we sometimes suggest. The research is limited on melatonin, and it's most effective for difficulty with sleep duration, but it has been shown to be in short-term use at least safe. So for short-term, say 3 months, to say break a cycle of insomnia. Our next topic is the use of appetite stimulants. So this topic reads, avoid using prescription appetite stimulants or high-calorie supplements, so those things like Ensure, Boost, that people often reach for treatment of anorexia or cachexia in older adults. Instead, optimize social supports, provide feeding assistance, and clarify patient goals and expectations. So a concerning geriatric syndrome is the phenomenon of unintentional weight loss in later life. This is, people have looked at both the incidence and the prevalence, and it's quite noteworthy that over 10% of older adults annually develop this condition. And at any given time, among older adults who are more frail, more high risk, in a study of older adults such as this receiving community-based services, almost a third of older adults were losing weight. What do we mean by involuntary weight loss? or unintentional weight loss. So people aren't dieting, they're just losing weight for reasons that we'll look at in a minute. But the loss of either 5% or more of their regular body weight in the course of a month, or 10% or more of their usual body weight over the course of 6 months or longer. So why does this happen as people age? Why do people develop difficulty with weight loss? Like other geriatric syndromes, one of the hallmarks, key hallmarks of geriatric syndromes is that they're so-called multifactorial, meaning although we'll look for a single cause, and in younger adults we might think, oh, somebody's developed a cancer or they're profoundly depressed, for example. A multifactorial condition like this, another multifactorial condition would be delirium or falls, that there usually is not one single etiology that we identify, even though we may look, but it's a combination of so-called factors or multiple factors, i.e. multifactorial. And an individual assessment to identify those factors is in order in cases where people are losing substantial amounts of weight. What do we look for? Again, a broad range of contributors here. Everything from changes in sensory inputs, so loss of smell leading to loss of taste or change in taste. So it could be, reduced taste, which is thought to be normal aging, to dysgeusia or abnormal taste. Impaired taste, mechanical problems with chewing, maybe dentures that aren't fitting, loss of weight often is associated with trouble with maintaining good denture fit, trouble with swallowing for any reason. There's a whole differential for that. Medications, always remember medications in any context. Ask, could a medication be contributing to this problem that this patient is exhibiting or complaining about? There are, again, we looked a bit at medications that can cause people to lose their appetite, have feelings of nausea or diarrhea, and I've just listed a few of those here. There's a number of medical conditions, endocrine conditions, such as hyperthyroidism, hyperparathyroidism, where people may be losing weight in that context. They might have trouble actually, due to mobility, accessing food or getting food into their home. Or they might have trouble with fine motor skills, where they can't actually hold a spoon, maybe a tremor, where they drop half the food that they pick up. Psychological issues can be at play, as well as social isolation, for example, or just eating alone every meal. Or they could have issues with getting food, affording food. So in this setting, as health professionals, it's common to recommend either some high-calorie supplements or sometimes even these appetite-stimulating drugs. And we know that these drugs have risks and they're not helpful. So let's look at the evidence around that next. So it turns out that there's minimal improvement in appetite and weight gain as a result of administration of these medications. Muscle strength is not improved as we would hope. Quality of life and survival are not improved, and no changes in physical functioning or disability are observed as a result of treating with these agents. And a summary of the untoward events that could result are listed here, and we can look a little bit more in detail at some of this data. This was a review article looking specifically at megestrol acetate used for unintentional weight loss, and you can see that the number needed to treat, although not large, is far outweighed by the number needed to harm, where the risk of venous thromboembolism, for example, only 2 patients need to be treated in order to set up the risk of that occurring. And so the risks are real, and the effects are modest. And the balance, again, when we're thinking about risk-benefit, are really the risks outweigh the benefits. In more recent years, in another medication that people have thought about and sometimes tried to increase weight in this setting is Mirtazapine, one of our newer agents for treatment of depression. And indeed, this medication does contribute to some increase in appetite and weight gain. It's actually a side effect of the medication that we see. And people may actually have quite a bit of weight gain as a result of starting on this medication. But it turns out that the weight gain occurs in the context of treatment of a mood disorder, but really is not occurring in other settings. So for somebody who is losing weight due to an underlying depression, certainly this is a good agent, but just to be aware that it's actually not useful in other patient settings, and that the weight gain could be achieved by use of other agents if other agents are more appropriate, even in the setting of depression. What about nutritional supplements? So these are very expensive generally, and this is a slide directly taken from the American Geriatric Society, illustrating the ingredients and the concern that this is often adopted as a substitute for eating solid food. So one of the key things is that people tend to reach for these instead of a meal. These originally were designed to be used as in-between meal supplements, truly supplements, but not replacements for a meal. But because they're easier to administer, people tend to take them at meals instead of administering a meal or preparing, if it's the individual, him or herself, their own meal. This is a summary of the nutritional value and the cost of, in addition to the taste, of common supplements, and comparing them both to low-fat yogurt and orange. So pretty comparable in terms of calories, really no fiber compared to the food. And at least with the yogurt, you're getting some, in addition to some fiber from the orange, you're getting some protein from the milk. And the cost of these are, again, numbers that the American Geriatric Society has provided from a study that was done quite a number of years ago. So you can imagine the costs are quite a bit higher now for these supplements by the can. And people generally don't like the taste of these, interestingly. So if you haven't tasted them yourself, go ahead and try, but just know that their value is minimal compared to the price. There are short-term studies of benefit in the hospital setting for using these supplements. So to try to distinguish a bit from setting to setting, lots of these principles apply in all settings, of course. The use of antipsychotics that we looked at, the percutaneous feeding tubes. Supplements may have a short-term benefit for people in the hospital, but in other situations, in other circumstances, their effects aren't comparable. So generally avoid. So what should we do instead if we don't offer these options to patients with weight loss? So looking again at this idea of assessment before treatment, we want to look at what might be contributing to weight loss in this individual, and then try to figure out how we can address each of those contributors. And we're looking again for reversible causes. So the things that we talked about, for example, around medications would be a key opportunity. Certainly any undiagnosed medical conditions would be another opportunity. And thinking broadly in the context of the psychosocial milieu, thinking not only about the medical but also the social factors, and making sure, for example, that people have an opportunity to eat some meals each week with other people. Intake is improved when people eat with others. Some other ideas here. If people have trouble feeding themselves for any reason, try to increase the support around feeding. Eliminating dietary restrictions is a big one. We often think we need to restrict salt, we need to restrict fats. Actually, as people age, restricting salt, we get away from. We want to enhance flavor in other ways if we can, certainly herbs and that sort of thing, but salt is not necessary to avoid, and it can be a flavor enhancing agent for people and make their food more palatable. Regular exercise to help people develop an appetite. If they're sedentary all day, that's not going to help with appetite, won't help with regular elimination, so trying to exercise and promote routine bowel movements. And then clarify what treatment goals and expectations are in each individual. So what is reasonable and what's desirable, and what do people want to change, trying to make sure we make this patient-centered. And lastly, this topic is around reviewing drug regimens. And specifically, if we're thinking about prescribing a new medication, we want to first do a medication review. We know that older adults their medication lists are long. They tend to take large numbers of medicines, and that's often indicated medications for common conditions. Any common conditions these days, such as coronary artery disease, hypertension, the treatment involves multiple medications, even for just one condition. There's also, with every condition, there's a guideline promoting treatment with medications, and when people develop multiple chronic conditions, oftentimes those guidelines may conflict or certainly will inflate the length of an individual's medication regimen. The other thing is that there may be potentially beneficial medications that are underused, so we can also look for that as part of medication review. So taking multiple medications inherently has risks. People will have trouble keeping up with their regimen. They may receive incorrect medications. They may have adverse drug reactions from any given medication or medications given in combination. And certainly, the more medications people take, the less likely they are going to be able to adhere for one reason or another. Cost, cognitive reasons, just simply keeping up and remembering to take them can become more and more problematic. And taking multiple medications can, in many instances, contribute to risk of adverse events. Those listed here: cognitive impairment, falls, and functional decline, and studies have demonstrated this. What is the purpose of a medication review? So, first of all, it gives us an opportunity to look at medications that are no longer necessary. And when I say no longer necessary, one of the things that often happens is that people do have medications that get continued over time. And there may have been an indication for that medication at one point in time, but it's reasonable to question, is that medication still relevant? And that takes a bit of time. Again, a review of these medications as the person is taking them currently, looking at their problem list and trying to do a matchup can be very helpful in determining necessity, but also reassessment of certain conditions might be in order. So for example, a mood disorder. somebody may have been treated with medication for that and no longer need it. They may be able to be tapered, for example. Medications that are clearly potentially harmful, those are some of the medications that we've talked about today, for example. And certainly in this age group, generally speaking, medications that have central nervous system effects would certainly be considered potentially harmful. But those medications are also described in more detail in documents such as the Beers criteria and the stop and start criteria. So if you want to look further into the idea of medications that are potentially harmful or inappropriate, those are some good resources. Also, just the opportunity to reduce medication burden. So there may be medicines that people aren't taking that are still on their list, for example, or medicines that they really don't want to take anymore, or again, maybe having adverse effects due to. So those medications often fall into the category of what I call medications used for symptomatic treatment. So for things, again, like sleep, that's a very common one, but oftentimes there may be other medications. For example, this might be an opportunity to look at what is the patient's pain regimen? Is there a substitute? Could there be a topical agent used as opposed to this oral drug, for example? And then, again, the idea of, are there indicated medications that aren't being administered? So, for example, a beta blocker in the setting of known, well-established coronary disease. And again, similar to what I was recommending in the context of our last topic, we want to think about this with the patient, looking at what their goals are, what we think their life expectancy remaining is, and think about time to benefit. So some drugs certainly have longer time to benefit than others. That is information that can be gleaned from various resources, including pharmacists, but publications in geriatrics that document that time to benefit. And also thinking about the burden of therapy. So some patients find taking medications much more burdensome than others. Most often I hear that people want to take fewer medications, so that's something to be aware of, that can help you partner with your patient around what is now becoming called deprescribing, and also just what contributes to their quality of life. Certain drugs require monitoring, for example, so if they don't want to come in for a blood draw or a shot on a regular basis, then that might not be a treatment that they want to continue with or start. So in the last few minutes, I have a few cases to illustrate some of these principles. And we could discuss these as part of the chat, and people in the room are welcome to join in the discussion. So the first case is of SM. She's 81. She has Parkinson's and advanced dementia. And she comes in, brought into clinic to see you by her husband, and he is starting to have trouble getting her to eat. She doesn't seem to really swallow well, and he's noticed that she's coughing. And you also notice that on exam, she is having difficulty with skin integrity. She has a new, very early, but a stage 1 pressure ulcer on her coccyx. So how would you approach this patient in your office? Common problem swallowing as Parkinson's associated dementia, or just Parkinson's alone without dementia progresses, is the emergence of swallowing issues. So we see that quite a bit. Any chats? Any place to start? So this is a good example of our first principle or topic, using or not using percutaneous feeding tubes, right? Hallmark in this would be to counsel the husband. So many family members can begin to implement this hand feeding or assisted oral feeding when counseled. It's not hard. They just have to prepare food that they can chop up, or as they might need to modify the texture, the texture might become important. They will need to prepare softer foods. You probably don't want to have a steak and necessarily, but softer foods like fish for good protein, vegetables that can be eaten with the hands, etc. And that would be the first place to start, and then observe and see how that works.
You're getting a lot of people weighing in and suggesting speech therapy, speech eval.
Mm-hmm. Right. So what would we find on the speech eval that would change our management, I guess?
We would be going down the percutaneous feeding tube route if we got speech involved, likely. Yeah. So this is common in that we're likely to find dysphagia and aspiration. But the idea is, what are we going to do about it? It's part of the condition. It's not going to change, and the tubes, as we've seen, that the evidence goes against use of those. So what speech might help document is textures that could be safe. So there would be potentially a role for that, and their recommendations could be useful in helping guide just how to feed, so safe feeding. So positions, for example, sitting upright. Don't feed somebody if they're on their side or slouched in their chair, certainly not in bed, etc. So there certainly could be a role for speech if that service is available. And it's not too onerous. Again, sometimes it becomes onerous just to get people to their appointments. So we really do have to weigh that, the workup burden, so to speak, and the visit burden, and counseling a husband such as this or another caregiver about this, and having them participate in that decision about how much of a workup do we need to engage in versus how much are you comfortable trying at home. And the more we can counsel people about simple things like position, we can learn from our speech therapists and adopt some of those recommendations as we go. Other chats before I move on to the next case?
Suggested to try and find out what, if anything, has changed in their overall psychosocial situation.
Mm-hmm. Sure. And so perhaps there's increasing isolation of both of them. For example, maybe there are other reasons for him having trouble getting her to initiate eating, in other words. The other thing is just making sure that good mouth care is maintained as much as possible. Again, it can be difficult in dementia to get people to brush their teeth. So there might be some oral factors that could be looked at here. A little bit of an oral exam, see if the mouth is dry, if there are signs of dental caries or teeth that look like they could be abscessed or infected.
So another suggestion was to determine her physical capability in order to maximize her activity.
Mm-hmm. Right, so exercise still being important to stimulate appetite. Yeah. Great. Second case, Mr. DV, who's an 84-year-old homeless man. He has dementia, diabetes, GERD, prostatic hypertrophy, depression, anxiety, and chronic insomnia. And he comes into clinic to see you, and he tells you that he's fallen and he has a lot of rib pain, and you suspect and confirm
that on imaging, you get a chest x-ray, that he has a number of rib fractures on the right side of his chest. And you're reviewing his medications, and you notice he's taking a lot of different medications, and amongst those, for his mood disorder, he's taking lorazepam, and for some reason he's also taking olanzapine. Unclear why. These are actually real cases, by the way. What concerns would you have about his medications given his fall?
They potentially led to his fall. Having.
Sure. Yeah.
Repeat.
So the comment was that they could have potentially contributed majorly to his fall, and that's absolutely right. He turns out, because of his depression with prominent anxiety features, he was getting this lorazepam because he was having difficulty sleeping at night. So this is an example of, he'd been prescribed a couple of drugs. We couldn't determine any history of psychosis from the chart. Was prescribed some medications for sleep that kind of backfired in the setting of him having falls as a result. And also with the olanzapine, remembering that it could unmask diabetes, so some concern about that in him as well. Good.
So Anchorage is suggested looking into who's administering the meds.
Mm-hmm. Sure. So, and in fact, this patient, because of his homeless state, is somewhat hard to get history from and track, but that would definitely be useful, because sometimes these medications get added on when a person is seeing multiple providers. They might have shown up in an ER, for example, or in addition to primary care, they might have been admitted to a hospital somewhere and ended up taking a number of medications that were being prescribed by different providers without each of those providers being aware of what the person had in their armamentarium already. So that's a great point. Other thoughts?
Someone suggested, I'm thinking about how they affect his inner ear and balance.
Sure, definitely. Benzodiazepines at least have adverse effects directly on balance, similar to alcohol, if you want to think about it that way.
And then someone says, has there been any questions about abuse to get his prescription drugs? I'm not sure if that means others trying to get his drugs or...
Yeah, those are all good thoughts. This is Mr. PG. He's your 78-year-old uncle, so this time you're interfacing with the primary care environment and trying to seek help here for your relative. So he, again, somebody with not uncommon list of chronic conditions: coronary artery disease, hypertension, COPD, and you're his durable power of attorney for healthcare. You stop by to see him about once a week to check on him as he lives alone, and he's become more listless recently, and he really isn't engaging with you, and you notice that his clothes seem to be fitting much more loosely. And you take him into his primary care provider and get a prescription for Enger from the provider. And so how would you respond in this situation?
It says here, I would have a concern for depression.
And I would have a concern for social isolation.
You want to repeat?
Sure. So in the room, in addition to depression, mentioned that social isolation could be a factor here as well. So this is an illustration of somebody who's losing weight based on the fact that his clothes fit loosely. In men, it's thought, you can ask them if they've had to put more notches in their belt, to tighten their belt, to keep their pants up, as a way to gauge weight loss. Weight is an important parameter to measure at each visit with your patients in clinic, and actually looking at those over time. So perhaps this wasn't data that the primary care provider actually had at hand. Our electronic medical records certainly are making it somewhat easier to gather certain types of information such as this over time, if it's checked at each visit. So worthwhile doing, certainly for people that you're seeing in this age group, and having your staff do that and document it is really useful to make sure that there's actually objective weight loss going on. In this case, based on the clothes fitting loosely and you as their relative being a fairly reliable, let's say, historian, I think as a primary care provider, we can rely on that history at least. So exactly what you're talking about, you're going down the path of looking at reasons why this phenomenon might be occurring, and both of those thoughts are, totally part of what you need to be investigating. So that broader view, again, trying to avoid the kind of impulse that we often have in practice when we're, looking at a long list of patients, or we're going in and you can tell that the primary care doc has one too many people to see that day. Having a chance to say, what do you think about this as a possibility, and could we look into this? Could we assess him? Maybe a mental health evaluation, for example, or in-home services to do an assessment to see, what kind of food is in his fridge, and does he seem to be taking care of his home environment, or is there self-neglect? This could, for example, also be apathy in the setting of dementia. So there's definitely a differential here. Last case, this is Mrs. M.W., a delightful 91-year-old lady. She has moderate dementia, osteoporosis, hypertension, hypothyroidism, and essential tremor. She presents to established primary care with you, and her review of symptoms is notable for generalized weakness and frequent heartburn. She has vital signs showing systolic blood pressure of 130 when she's lying, which drops to 110 when she stands, and she's on a number of medications listed here: donepezil, valsartan, propranolol, and levothyroxine. This is our topic around medication review. First of all, we're not thinking about necessarily adding a medication in this case, but it's still an opportunity because she's having some symptoms to look at whether or not there might be medication reduction opportunities. So with that as a hint, what medication changes would you recommend? Changes could be adds or subtractions, tapers, reductions. And just looking again at she does have a number of chronic conditions, some of which are being treated by these medications. So what are, starting with what are some of the things that you notice that would concern you in this patient? Anything from her symptoms to her vital signs?
They're talking about decreasing blood pressure meds slightly, and reviewing the PDR to see what overlaps might exist and go from there. And reducing or stopping the donepezil and valsartan. Sure. Right, so let's take one of those, each of those things at a time. So she's having a postural drop in her blood pressure, that going from 130 systolic to 110 when she changes positions. That is that drop of 20 points 20 millimeters of mercury, is diagnostic of what we call orthostatic hypotension, commonly seen in older adults. The prevalence is about 30% in community-dwelling older adults, and it's under-recognized. You actually have to look for it. And certainly, she does have hypertension, and treating hypertension is important, but her blood pressure is really well controlled and we might say too well controlled. So from the standpoint of treatment, reducing the doses of her antihypertensives would be appropriate to try to mitigate this finding of orthostasis. We see that most commonly in people who are taking more than one agent that lowers blood pressure. She happened to be taking the propranolol for her tremor, and so she is on a dose of valsartan that could be reduced. So taking the principle of making one change at a time and then observing the effects. So just like we want to not put people in this age group on a high dose of a new medication to start with, but we rather want to start low and go slow and up titrating the medication. We also want to taper gradually just to avoid rebound hypertension or whatever it is, withdrawal effects from any given medication. So it would be appropriate to dose reduce one of these agents. Her husband actually, who was with her, said she used to be really bothered by that tremor, so I'm kind of reluctant to reduce the propranolol. So valsartan was a good candidate for dose reduction there. Second, with her heartburn, and somebody mentioned the donepezil. So that was one of the medications that I called out here because I mentioned it earlier in the context of being a drug that can contribute to nausea, upset stomach, diarrhea, just basically gastrointestinal upset. And although she has dementia, it turns out that it was felt that her dementia, and I didn't mention this before, but was a mixture of vasculotype. She'd had a history of strokes on imaging. So probably donepezil might not be the most indicated drug. It's typically thought to be of benefit and looked at in trials of people with Alzheimer type dementia. So that would definitely be a good option for her in terms of trying to see if there were medications that you could reduce. Perhaps reducing again to half that dose or a trial off. Typically, if we are going to use that, we'll try to get caregiver input about whether or not they think it's helped with cognitive function, and it's very subjective, and it's not, again, a medication that has large effects, so if we think it could be contributing to side effects and the benefits are minimal at best, thinking about, again, that risk balance and talking with our patients about what the risk-benefit ratio is, that would be one that we could consider eliminating.
And someone from Fairbanks asked about seeing if levothyroxine is appropriately dosed.
Mm-hmm. Sure. So maybe she feels weak because she's undertreated for hypothyroidism, for example. So that's a good thought. You could check just a thyroid function. The other thing in her is the issue of her. She's treated for her chronic conditions with the exception of her osteoporosis. So that's another thought. So again, illustrating an idea of underuse of necessary medication. So she actually had on DEXA scan severe level of osteoporosis and yet was untreated. Had, to her husband's knowledge, never been on a treatment. So thinking about indicated medications, that would be one that we would typically recommend in the setting of a lot of GI distress. That would be potentially troublesome to start right away. But again, another example of something where we might have an opportunity that we can create if we alleviated some of her heartburn, for example.
So then there's just another suggestion to consider other etiologies for heartburn and weakness.
Sure. And first thinking about, again, medications as a culprit. In clinic visits that are short, And then if there are culprits, then addressing those first and seeing effects of that may help you avoid a lot of lengthy workup for other causes of these symptoms. So just to conclude, treatments that might be helpful for younger adults may not be safe or reliable in older people because of physical changes of aging. So it's really key to initiate conversations about potentially unnecessary tests or treatments, which is the mantra of choosing wisely, avoid unnecessary treatment and the concomitant risks. And encourage patients to ask questions. So just like when you're in there in the driver's seat in the office, you would be armed to ask questions. Really invite your patients to question why you're suggesting things, or explain to them so that they understand why you're explaining the things that you are. Can really go a long way to help them choose wisely in the course of their health care. So thank you very much.
So these are, I think, some more general questions, and people feel free to chime in. They're asking about addressing the proper dosage of melatonin for older adults.
Mm-hmm. Yeah, it comes in a number of different strengths, and I would recommend doing the same thing that we would do with any other medication, even though this is an over-the-counter medicine. It comes in as low as 1 milligram. 3 milligrams would be a reasonable place to start, and dosing that an hour, at least an hour before bedtime, so it has a chance to kick in. It can be up-titrated, of course. Oftentimes we'll use more than 3 milligrams, but we want to use the lowest effective dose. So if we start at a dose like 3 milligrams and the person's sleep improves, then there's really no need to increase further.
What's the duration for adjusting dose? Like 3 days at one dose, and it doesn't work at alone, or what's your suggestion?
Yeah, for most medications, you know, again,
She's asking, isn't it?
oh, sorry, yeah, she wanted to know how frequently to up-titrate medications. Sometimes the effects of medications, I'm going to speak more generally now, not just to melatonin, but kind of a broader principle is that it takes a while for the full effects of medication to be seen sometimes, especially medications used for chronic conditions. That's true, for example, of blood pressure lowering agents. So I would say err on the side of going up-titrating less rapidly. So, you know, once to twice a week, for example, in melatonin, so give them 4 to 7 days. We do that again with antidepressant agents. So like if you're starting an SSRI, a daily up-titration probably will lead to discontinuation. So if you up-titrate the dose every 7 days at a minimum frequency, that would be advisable.
Other questions in the room? I don't see other questions other than lots. Oh, here. How do you include an interprofessional team in the Choose Wisely process? It's interesting.
Mm-hmm. Well, tying that to the primary care setting, because that's our focus here with our lecture series, that can depend on your team available, certainly. So if your team consists of medical assistants, for example, and nursing, perhaps pharmacists, perhaps social work, that could be a team that could help with everything from making sure that you're checking things like blood pressure with position changes or standing blood pressures to look for some adverse effects of medications at check-in, to consulting with a pharmacist about history of medication use, duration, that kind of thing. Pharmacists can actually, in my experience, gather information about long-term use of medications that can be helpful in making decisions. If you have several medications that you're unsure about whether or not it's one versus the other that you may want to target for reduction, and which one to start first. And then certainly social work assistance to increase in-home services, get mental health assessments scheduled, and nurses for if you have a nurse in your clinic for monitoring changes in between visits can be very helpful. Talking with the families, having the nurse available for questions, and just being aware generally of what the treatment plan is so that they can help monitor it with you would be really, really useful.
So Prestige Care is asking in regard to the use of feeding tubes. Do you reference literature? Were the studies examining hospitalized or non-hospitalized adults?
A combination, but these are, this is an evidence base that is not generally a randomized trial type of evidence base. Great.
All right.
Thank
you very much.
Hard to leave the clapping when I have the microphone in my hand. Thank you.
And I don't know when it shuts down, when it shuts off.